Good afternoon. Welcome to this month's Northern Virginia Health Policy Forum. I'm Brittany Locatore, the Vice President of Health Policy at Applied Policy, a health policy and reimbursement consulting firm based in Alexandria, Virginia. My colleagues and I host these gatherings every month to explore critical issues shaping American healthcare. Today, we welcome Jeff Blue, who is the Deputy Director for Policy for the CMS Center for Consumer Information and Insurance Oversight, known as the CIO. CIO is responsible for regulating and overseeing the Affordable Care Act, marketplaces, and ensuring that insurance plans comply with the ACA requirements. Welcome, Jeff. So you have had a very interesting and influential career at CMS with 16 years of service. How did you get to this point in your career, and could you talk a little bit about your career path?
Sure. And Brittany, thank you for having me. Thanks to Applied Policy and the Health Forum, the Health Policy Forum for having me. We've had a number of folks from our agency come here over the years to speak, and we always see this as a wonderful opportunity to engage, to answer questions, and exchange points of view. It's a great opportunity for us. So 16 years, it hasn't felt like that. That has gone by very quickly. Like many folks in federal service, my original intention was to come into federal service just for a short stint. I was thinking 2 to 4 years. My wife and I did the math, and we were trying to figure out how long I could afford to do so. Before coming to and then stuff happens, and you pick up responsibilities, and then you pick up obligations, almost like public obligations or obligations to sort of see through, what you started and see through a program, and that has made it complicated for me to leave. And so I have year after year chosen to stay and continue with the work. And I will also just sort of say, as an aside, and Brittany, you are a former colleague of mine and know CMS well. But part of the difficulty of leaving federal service is you have these amazing colleagues who are dedicated and hardworking and incredibly smart. And it's such a pleasure working with them all of the time. It just is hard to leave. So I started, I suppose, sort of as a corporate lawyer. I worked for a big DC law firm. I started out in California, but we moved to DC. And so I practiced corporate law for many years. I ended up in this role because at my law firm, I noticed that a lot of the senior partners had done a stint in public service in some capacity, whether the Department of Justice, many of them at the Department of Justice, or in the various agencies, the State Department, HHS, the FDA. A lot of my colleagues had been at the FDA, or the FCC, or agencies like that. And I worked for a big DC law firm, and we prided ourselves on being able to help clients navigate through the federal agencies. And so I thought that it would be a very cool thing to go and spend some time in public service. And then the way these things work is it's a little bit random, a little bit luck, and a little bit like kind of being there when stuff happens. The Affordable Care Act passed. I saw it as a sort of once in a career opportunity to sort of really grab onto some big levers and try to make a difference in in a big problem, in a big domestic problem. It happens to be that the judge that I clerked for, the late wonderful Judge John Noonan from the Ninth Circuit Court of Appeals in California, his son, whom I grew close with, had been working to staff up the HHS agencies, in particular CMS and CIO, after the passage of the Affordable Care Act. And he and I were talking, and he said, you should come in and meet some people. You might be really interested in this work. We're building a team, and we've got a lot of work to do to implement this law. And I came over and I met some people, and I thought this could be kind of fun for a while. And so here I am. So a little bit of serendipity. It is, I did not, my practice was not sort of squarely in health coverage or health insurance or even health. I did a little bit of drug stuff. But I was a deal lawyer. I did mergers and acquisitions and licensing deals. But many of those skills are very transferable. And I crossed over, fell in love with the work, and can't turn myself away.
Wow, that really is serendipitous. I can't imagine a more interesting time or way to come into the government, really.
Well, it was a tough the first couple of years were pretty tough. And luckily I was coming from an environment in which if you do mergers and acquisitions, it's also a very intense lifestyle. Deals break, on Friday, and you're working all weekend, and then you're negotiating all week, and you're working all hours and the like. So I had my whole career, I had been an adrenaline junkie. So implementing the Affordable Care Act sort of fit right into that. And, it was all excitement and all craziness all the time. And it still is, quite frankly. And I suspect we'll end up talking about some of the current challenges. So the transition perhaps was not as difficult as it seems, but it was, it's been a very topsy-turvy ride.
Well, speaking of the exchanges, could you give us a little background of sort of the state of where they are now and maybe some insight into what's new with the exchanges, any new projects? I know ICRAs are one
Yep.
thing that people are kind of excited about over there. Do you want to talk about it a little?
Yeah, sure. So the part of CMS that I help lead is as Brittany, as you said earlier, SOCIO, which is the part that focuses on the Affordable Care Act private insurance pieces. And so that is the exchanges, that's regulation of group health plans, which we do in connection with the Department of Labor and the Treasury and the IRS. But a big operational focus of ours is running the federal exchange, was standing up the federal exchange, running the federal exchange today, and governing and working with all of the state-based exchanges. And for folks who are sort of really coming to perhaps new to health insurance, the exchanges collectively now largely dominate the individual market, right? There was an individual market long before the exchanges came along. The Affordable Care Act completely changed the way the individual market worked and stood up these exchanges and made subsidies available for folks to purchase insurance through the exchanges, which, and along with guaranteed issue, was a complete game changer, such that the individual market today I think of as really a foundational health coverage market for this country. It is still, we are still only 20, 30 million people covered lives, so we are not as big as group health insurance, of course, which dominates health coverage in this country, or Medicare or Medicaid. But it is for many folks, it is the market of last resort, or a transitional market for folks who are between jobs, for folks who are gig workers or sort of work for themselves. It is the market that tells them that no matter what happens, there's a market here for you. You can come and get coverage. And I think that is a huge game changer for the economy. And so standing up the exchanges has been sort of the main long-term project of SOCIO and of me these years. These markets have grown and grown and grown. We are over 20 million covered lives in the exchanges, and then lots of people in the individual market outside of the exchanges. Though, as I say, the exchanges now dominate these markets. The exchanges go through periods of up and down because, unfortunately, one theme in healthcare in America, unfortunately, is that the dollars are big, and perhaps partially because of that, it's a political football, and so political turbulence comes into these markets from time to time, and we're going through a cycle right now of that. There are enhanced federal subsidies that have been in place basically since COVID, and are due to expire this fall, which would result in very substantial net premium increases for lots and lots of people. And Congress is continuing to talk about and grapple with the implications of that. For many of the folks who are on these plans, the implications are quite important, quite profound, and we will see what if anything Congress chooses to do over the next number of months. That is a particularly hairy process right now because we are so far into the cycle already that any changes are going to be very last minute and create all kinds of operational challenges. And that's one of the things that we are trying to manage right now, along with all of our partners in the states. The process of managing private health insurance is complicated because traditionally states have primary jurisdiction over governing health insurance, including in the individual market. And so we sort of work in partnership with them. Even where we run the exchange, they are still regulating these plans. And so we work with states to get all these plans across the line and onto the exchanges so folks can enroll. So we have this very tight partnership with states. We have tight partnership with our state-based exchange colleagues, and we have tight partnerships with Medicaid agencies all over the country as well, because lots of folks are in sort of this zone where they are moving back and forth between Medicaid and exchange coverage because of sort of their income and how it might fluctuate and how the rules might change. So it's a complex endeavor. So I would say the biggest thing that is happening right now is the exchange and the individual markets are trying to manage all of the change that may or may not be happening this fall and going into a very uncertain open enrollment. On the policy front, I guess I would say that there are a couple of three big patterns that are worth calling attention to. One is over the last couple of years, we've been very focused on rooting out agent broker fraud. We've had a number of cases. We've had a lot of cases, reported cases where agents have been unscrupulous agents really have been suckering people into coverage or putting people into coverage without their knowledge by getting their personal information and basically trying to sort of steal a commission stream from the insurance companies. This has been partially facilitated, I guess, by the existence of the enhanced subsidies, which create the opportunity for lots of folks to get $0 plans. Which is great if you are a person with low income and need coverage, but it also makes it very easy for a fraudster to come in and put you on a coverage you're not even aware of until it comes time to reconcile your taxes, and then that's where the problems really start. There's one pattern, and we've been sort of really focused the last couple of years on rooting that out, and we are seeing the numbers come down, and we're making good progress there. But there's still a problem, and we are still very focused on that. The second are sort of probably more positive stories. The second is big focus right now on transparency and bringing change to the commercial market so that there's more price transparency. There's more transparency with respect to the bills, the medical bills that you get, and this involves a lot of work. And this is not just an exchange issue. This is sort of all across all of commercial health, and there are big exciting changes coming on that front. And the third, I think worth mentioning, Brittany, is what you mentioned, ICHRAs, which are individual coverage HRAs. These have been in place actually for a good 5 years now, but because of COVID, I think COVID sort of like messed up the take up of these instruments. And what these are an HRA is an account-based benefit that a company can give an employee to help them afford or pay for health expenses. An individual coverage HRA is a form of HRA that we created through a rule that allows the company to provide you dollars, and instead of offering you a group health plan, just give you money as you, the employee, and say, hey, just go to the exchange and just purchase what you want. You don't have to, take the plan that the benefits office decided was the right plan, and maybe your physician is not in the plan or whatever. Here are the dollars. It's easier on us, the company, because we don't have to administer this plan anymore. and go and purchase the plan that's right for you. And for some folks, that'll be, a high benefits plan, a gold plan, or something with the deep network, or with the provider of the hospital that they really want to see, or the drug coverage that they really want. And for others, it might be, a much, lower cost bronze plan, or a certain specialized kind of plan. And so I'm long-term quite bullish on the prospect of this additional benefit being available for particularly, I think, small businesses who have, the administrative burden of administering a health plan is significant. They're not specialists. They don't have like big benefits departments to sort of handle this stuff. And the idea of like, okay, let's figure out the right dollar amount, and then put the dollars aside for our employees and let them go and pick their plan. The additional benefit here, I think, long term for the economy, is that when we get and I think this is coming eventually, inevitably, when we get to a critical mass of folks in ICHRAs, it really changes the game in terms of job mobility. So we all know folks who feel like they are locked into their job because they want to hold on to the health insurance. But instead, if many jobs are giving you the funds or putting funds into this account for you to purchase the health insurance yourself on the exchange, then that coverage is yours. Is not explicitly tied to the job. You can move to another employer. That other employer may also just give you the money to put into that account and have you purchase that coverage. It's still the same plan. You're not resetting your deductibles in the middle of the year as you change jobs. Or if you leave your job and are without coverage for some number of months, COBRA is very expensive. You don't have to worry about COBRA and these sorts of things. You can just sort of stay on your plan, pay those premiums until you get into your new ICHRA with your new employer. So it can be very helpful, I think, in moving us to a system long term in which folks are not locked into their jobs because of health benefits. And I think that'll have great benefits for mobility and the economy generally. And long term, it goes to this vision of the individual market as sort of the backbone market for health coverage nationally.
Seems like it would offer kind of optimal flexibility for the individuals and the employers, really. So that's
right.
That's really
Yes, and that's why we're very excited about it. Take up. I think take up is one of these phenomenons where take up is growing quickly, but from a very small base. There's lots of education to do. There's lots of employers do not understand what these things are, and understandably, it's very complicated. The rules are complicated, and the rules are complicated because as we wrote the rules, we were navigating between all kinds of statutory requirements under ERISA, under the tax code, and the like to sort of make this work. But I do think long term, and I think over time, Congress will get more and more involved and create more flexibilities here, and have these accounts be applicable in more situations, and we will learn more as more folks get into these accounts. Right now, there are a number of guardrails that are in place to make sure that these aren't just dumping grounds for sick employees and this sort of thing, that it is sort of viewed as just sort of a replacement for a group health plan. And it may be over time we'll be able to take those guardrails off and make this sort of easier and simpler for folks to use. So long term, Brittany, I'm very bullish about this and bullish about the way that it will tie sort of all of us together in sort of one more centralized commercial market. I think there will always be a place for, large group health insurance, that continues to be sort of the leading form of insurance in our country and will be for a long, long, long time. And it provides good benefits, and large companies know how to administer that, and that's all great. But this is, it's the cracks in our system that we're trying to plug.
Yeah, definitely exciting. Can't wait to see what happens in that space. Another thing that you mentioned was transparency, and the No Surprises Act obviously is a big move in the direction of creating more transparency for multiple stakeholders in the healthcare system. Could you talk a little bit about that and what's happening in that space from your perspective?
Yeah, sure. So the No Surprises Act was, really the most significant statutory change to commercial insurance since the Affordable Care Act, which I guess maybe was not that long ago, but in any event, was a very, very sweeping change to the way health insurance works, and it was trying to address this problem of surprise bills, which was a gigantic problem for anyone who knows anyone who's been caught by a surprise bill. They were making people's lives miserable. The No Surprises Act, like most pieces of legislation that get across the line these days, is a very complicated act. And I think of it as largely having two different sections. The first basically says there will be no more surprise bills in the following circumstances. And the circumstances are like, you're getting emergency care or you're going to an in-network hospital. But like, the anesthesiologist comes on and isn't in your network, and you've already been scheduled. You don't know. I mean, you didn't pick the anesthesiologist, you just picked the hospital, you just picked the surgeon. And there were lots and lots of instances where folks were getting surprise bills from these secondary providers coming in on procedures where the patient had done everything that one would expect them to do. They had selected an in-network primary surgeon, they had selected an in-network facility, a hospital to do it in, and suddenly there's this like assistant surgeon coming in, or the radiologist or whoever coming in, and suddenly you're getting these big bills, and your insurance tells you, these are out-of-network providers. We only cover this minimum amount. The rest is on you. It's a huge problem. I think folks realized it was a huge problem, but did not realize the extent of the problem until this law came into place. The law says, in these circumstances, emergency services and when you go in network, but like out of network providers sort of jump on, in those circumstances, no balance billing allowed. So those providers are now not allowed to send, the bill to the patient. They bill the insurance company, which is fantastic. The estimates are like 1 million surprise bills a month are avoided because of the impact of this law. That's like 1 million families, right, every month, like avoiding the misery of surprise bills. Many of these bills are, potentially bankrupting folks. But then the question becomes, so how much do these providers get paid? Because they don't have by definition, they don't have a contract and agreement with the insurance company. They're out of network. So they have not come to a meeting of the minds as to what those payments are going to be. And so the No Surprises Act sets up an arbitration system, essentially, which CMS administers, under which both sides sort of submit a bid and the arbitrator selects how much payment there's going to be. CSIO has stood up and been running the system for a number of years now, since the passage of the No Surprises Act. And what we found was, we just got enormous volumes. There's millions and millions and millions of claims coming in because while everyone realized there was a problem, I don't think anyone realized how big the problem was until the volume came in. And so we've been sort of battling through those disputes, and we're really starting to drive down the backlog of disputes getting resolved. But every month, many hundreds of thousands of disputes are getting arbitrated between providers and insurers. That's sort of one half of the No Surprises Act, and sort of the most public visible part. And I think that itself is a game changer because of all of the uncertainty. You hear about folks who, like, even when they're having a heart attack, like, don't want to get in the ambulance because they're afraid of bankrupting the family. I will flag, ground ambulances are one of the services not covered by the No Surprises Act. So there's still an issue there, but that is an example. Air ambulances, so the helicopters that were helicoptering, medevacing you off a mountainside or something, those are covered by the No Surprises Act, and it would often happen. And those are expensive forms of transport, and it would often happen that folks would get medevaced somewhere. Perhaps it was very important that happened. They would receive their care, and then they would receive a bill for whatever, $150,000. and would be left trying to figure out how they were going to lead their life with a bill like that. And the No Surprises Act handles that. The other half of the No Surprises Act, also extremely important long term, has a whole number of provisions that really go to transparency. They go to transparency of provider directories and accuracy of provider directories, and that's something that we'll be leaning hard into to sort of try to clean up provider directories so that folks sort of can, are not mistaken by sort of who's in network, who's out of network, and the like. Sounds very simple. Actually, it's a fiendishly complicated problem because of the way that our health industry works and how often folks are coming in and out of network. Those directories are constantly are surprisingly inaccurate. Transparency around pricing. There is a very ambitious set of provisions in the No Surprises Act that provides for advanced explanations of benefits. So the explanation of benefits is the set of documents you get after you have a service that says, here are all the things that the hospital provided you, and here are all the codes that no one except for folks in the industry really understand what the codes are. And then here's all the bill, all the dollars amounts, and here's the total, and here's how much your insurance paid and all that. So the idea here is that you would get one of those in advance of the procedure. So you would know what's coming, which services are coming, how much it's all going to cost, how much your insurance is going to cover, and how much therefore you are on the hook for. This is like what happens when you bring your car in for repairs. They give you an estimate right up front. If there's more work to be done once they get into the car than they initially thought, they call you. They ask for your authorization to bill something. That is sort of not what happens in healthcare today. And it's a very strange system that we have set up. So I'm very bullish about the long-term impact of this process. We have been years sort of setting up this process because there's all kinds of data standards that we have to work out between providers and insurance companies to make sure that everyone's transmitting the right data so that these forms can get generated. And then we have to create all kinds of rules around the forms and liability and all of that. But that is another example of the transparency that is coming that we are still implementing with the No Surprises Act.
Well, that's a lot.
Yeah. We've been very busy. Yeah.
So do you think that with all of these changes in this No Surprises Act and other program integrity efforts that we've been seeing out of CSIO and CMS generally, do you think that this is changing the way that commercial healthcare is working as an industry and the way that they're approaching the way that they're entering these markets?
I mean, that's a good question. I guess I would say that there's lots of change happening. This is one of the causes of that change. But the reality is this is a very dynamic market, the commercial health care market. And there's always different forces in play. And so implementing these laws, within that context it's important to be very sensitive to sort of what is happening in that context. I think the industry, both providers and payers, have understood over these last number of years how important it is to the American public that greater transparency come into play. You hear all these fights, with respect to drug pricing and PBMs and the like, for example. And all of these players, we have a very complicated healthcare system. There's a lot of money involved, and there are lots of stakeholders with different interests that administer a very, very complicated system. And there's reasons for that complexity. The provision of healthcare is complicated, and there's very advanced technologies involved, and so it stands to reason that there are lots of specialized players. But making that system work harmoniously on behalf of the consumer, which is what everyone wants ultimately, takes some coordination and takes some work. The No Surprises Act, for sure, and some of the things that we have been talking about are big forces here that we are using to try to sort of coordinate the system. I do think that in the years to come, we're going to see much greater coordination between providers and payers around billing, around pricing, around networks, around another topic that I think is worthy of some discussion now, that is a topic that's coming, is around prior authorization. So this is a practice that I think has been getting lots and lots of attention, because it's become a pain point. And it's become a pain point for providers who find that just a huge amount of their time is taken up trying to get approval from the insurance company before they do the procedure, and from patients who are finding that all of their procedures are denied and are wondering what the heck the point of having insurance is for if you cannot actually get these procedures paid for. And we are seeing all of that boil up into frustration and therefore political movement as well. I think industry is well aware. I think there's lots of efforts from many of the stakeholders to work together to try to coordinate solutions. And I'll call it one example, particularly in the prior auth area. A couple of months ago, it would have been June, a large number of health insurance companies, including the biggest ones in the country, came together and issued a statement of principles, where they said, our goal is to dramatically improve the prior authorization experience along the following dimensions. And there were dimensions like, we're going to remove X% of all the codes that we subject to prior authorization so that they're no longer subject to prior authorization. We're going to adjudicate 80% of all of these in real time so they just get submitted and then you get a yes or no right away. We're going to make sure that there's a medical professional involved in any denial. All of these, there are many aspects of this. A lot of this is very technical, data exchange rules that will drive this. But that was I think a really significant, really positive development. CMS and HHS are working very closely with the payer industry to implement that statement of principles, to make sure that everyone has sort of the same set of metrics to use, to set forth our expectations for industry as to how this is gonna work. And my hope is that actually we can pull this off without regulation or without significant regulation, and significantly shift the industry in a positive way. We will see. A bunch of this stuff is intended to leverage advanced technologies, for example, artificial intelligence or something like it, sort of advanced ways of sorting through complex data, as well as standardized data interchange formats to make all of this work so that you don't have to build a connection, an individualized connection between every provider and every payer. For example, you want to have one set of standards everyone can implement and then have the data, flowing naturally. So come back to your original question, Brittany, about sort of forces changing the industry. It is a complex industry. There are a lot of forces in play, and I think it's part of society's job to try to keep pushing along all those fronts to try to bring this industry together to serve our patients better.
Well, you just kind of touched a little bit there on what is probably one of the hottest topics in the industry right now, which is artificial intelligence. And obviously, artificial intelligence or the use of higher technologies played a huge part in those 6 AHIP promises that you were talking about. But everyone's very interested in how AI is having an impact on all different aspects of health insurance in the healthcare industry. Is there anything else that you'd like to talk about in that space and the impact of AI on societal policy and operations generally and in the future?
Yeah, we, like everyone else, I think, are still trying to figure this all out. I do think there's no question that lots of people think that there's going to be a very profound long-term impact from the application of these technologies in a healthcare context. Exactly what that's going to look like, we will see. I mean, I think the early applications that we see and use a lot are the use of AI, like physicians using AI to take notes of all of their encounters, to summarize their encounters, to, automate their communications, their emails with, with patients. This will speed all of that up, so that they can, instead of, doing the entire exam, sitting in front of the computer, typing all this stuff in, there is, a speaker sort of capturing everything and putting it automatically into the notes. And that's happening right now. There are use cases, there's certainly back office use cases involved around just even like scheduling of nursing staffing and this sort of stuff, around appointment scheduling. There's back office stuff around fraud detection. I think we're going to see a lot of back office work focused on coding, and communication of those codes back and forth between payers, providers, and government regulators. I think that's going to be an area of great interest. So like all industries, I think the healthcare industry is working through where the impacts are going to be and what this is going to mean and how we are going to sort of work through all of this. CSIRO and CMS itself, we are examining very closely a number of use cases across our enterprise around some of these same areas, trying to train up our staff to use these technologies to leverage their capabilities, trying to figure out what other ways we can make data available to folks using these technologies. I am in particular very interested and bullish on the idea of the use of, whether it's artificial intelligence or some sort of large data sorting technology to smooth these data transfers, these complicated data transfers between parties. And part of that can feed into like a prior authorization solution, for example. So if every payer has, in a standardized way, a setup that lists all of their prior authorization requirements that are easily ingested and consumed by and understood by some kind of agent for a provider, then suddenly the provider is not like looking through books and trying to figure out what they have to submit for any particular procedure to get authorization. Their agent is like automatically taking the data from their encounter and feeding it through, and perhaps we're getting a real-time adjudication. We can move to something much smoother while also retaining some of the benefits of a prior authorization or an authorization process. We are not there yet, far from it. We're going to need to make sure that we set up data interchanges, that we set up transparent documentation requirements and all of this to sort of facilitate the growth of that kind of mechanism. But I'm hopeful that we can push in that direction and use technology to smooth out some of the real frictions that have come into the modern practice of healthcare.
Thanks for that. That's really fascinating, and can't wait to see what comes of all of this. We do have a question from the audience that I'd like to pose, if that's all right. Going back to something you mentioned earlier about the advanced EOBs, our audience member is asking, what is the time frame for these EOBs, and could you talk a little bit about the liability associated with them?
Yeah, sure. So time frame is hard to pin down. So we have been working the last number of years on trying to lock down the data standards, the data interchange standards. And there's really two sets of data interchange standards that need to be. I mean, they don't have to be standardized, but I think we think that this will work way better if these are standardized. Otherwise, you're asking every provider and every payer to negotiate their own data interchange standards. The idea is there'll be one set of data interchange standards, but you need to think about both how providers and payers are interacting, because providers need to be able to, put down, okay, these are the services I'm going to be, that I think I'm going to be offering. And then that information has to get communicated to the payer. The payer has to sort of automatically look up all those prices, set them against the patient's like current deductible or copays or cost sharing or whatever, to generate a statement that's going to be like, here are the services, here are the codes, here are the dollar amounts involved, here's your liability, right? And here's how much comes out of your deductible and all of that sort of thing. So it's a complex interaction between them. So we've been locking down those data standards, and we have made, I think we're pretty much there on those data standards. There's another set of data standards that that also need to locking down, which is between providers. So often what happens is you go to your provider, perhaps your surgeon, your hand surgeon, and they need help, from a number of other providers. It should not be up to the patient to run around and find an anesthesiologist and get a bid from them and run around and go find a nurse or a secondary surgeon and the like, because quite frankly the coordinating provider is probably pulling in their network of folks anyhow. They have a team that they assemble and do this, but traditionally what often happens right now is everyone just kind of sends in their bills to the insurance company after the fact, and so no one has any real full picture as to what's going on until after the fact. So we need a system in which the providers are also communicating with each other and submitting all of these codes in so that they can all go into the advanced explanation of benefits to be provided to the consumer. This is super complicated, right? Like when you think about how this infrastructure is all going to have to work together. So that set of standards we are still working through. That is not going to stop us from sort of moving ahead at this point. We're going to move ahead with sort of the more simplified version of like one primary provider, and then we'll have some estimates or whatever in place for secondary providers. We're going to have to go through rulemaking, which in Brittany you're very familiar with, but the process, the way CMS, the way government agencies implement statutes in a binding way and put meat on the bones of statutory requirements is to issue rules and say, okay, we expect, we'll have to issue a rule that says all providers must use the following standards and all payers must accept the following standards and vice versa. And the payers must generate a form that looks like this and must have the following data and all that. So we need to put out rules on this. They're going to be probably waves of rules because we're going to start with sort of a big set of framework rules, and then we're going to have to refine as we learn more. Each rule, you go through, you put out a proposal, you take, in this case, there'll be no doubt tens of thousands of comments will come in from all sorts of interested folks. There'll be tons of valuable information in there, but it'll be a lot of work to go through these comments, and then we'll issue a final rule. We'll probably have to do this multiple times, but so it will be an incremental process. We have not yet issued our first proposed rule on this, so we are still like a couple of years out before like all this stuff gets locked down. But I think we will see stages here. I do think that in the next year or so, roughly, we will have a proposed rule out on this with standards required and the like, and then that will be definitely the starting gun for industry, like telling industry, okay, this is our path. You should start building now because we're going to expect you to be fully compliant by date X. So there will be a process there. I don't have hard dates because we have not published anything, and we have not. We are still, quite frankly, working those out.
You're explaining it so well that it almost sounds simple. But I know that it is not.
It is definitely not simple. That suggests I'm not explaining it well at all because it is not at all simple. So.
No, that's great. Well, let me ask one more quick question related to a recent rule while we're on the topic of rulemaking. The Marketplace Integrity and Affordability Final Rule. It was released back in June, and it's currently under an injunction from a federal district judge. Could you maybe quickly put on your lawyer hat and explain what that means for the rule to be under injunction?
Just sort of stepping back, healthcare is very complicated. There are lots and lots of stakeholders involved. There's a lot of money involved. A lot of stakeholders have very strong feelings about how statutes should be implemented or how programs should be implemented. And sometimes that means that, and they will not always love what the government decides to do. And this is America. You have the right to petition the government, and you have the right to sue the government. And so that is what happens. In this case, so when the Trump administration came in this most recent Trump 2 came in, CSIO very quickly put out the rule, Brittany, that you just mentioned, the marketplace integrity rule. And that rule was meant to, and I had mentioned the agent broker fraud problem that we have been tackling over the last couple of years earlier. That was meant to put in place a number of measures to both increase our ability to enforce our rules, and also to eliminate some of the incentives for agents to engage in this, as well as a number of other provisions that were intended to sort of save dollars and provide flexibilities and the like. It very often happens that in the healthcare context, there are folks who don't like rules, the way rules get implemented and finalized. And so a number of plaintiffs, in this case, it was a number of cities, the city of Columbus, the city of Baltimore, and the city of Chicago, along with a number of organizations, sued on that rule and said, look, that rule is going to reduce the availability of health insurance in our markets, and is going to saddle us with more uncompensated care, us as cities and operators of healthcare facilities. And then, they raised a number of arguments as to why that would happen and why the rule was not permitted under the statute. What happened was, and they said, Judge, please rule very quickly, because this rule is scheduled to go into effect on August 25th, I think it was, or 27th, or something like that. The rule had been proposed back in March, and Brittany, like you said, it was finalized in June. That is that's a very quick schedule for a rule. That happens, I mean, in society's experience, what happens is whenever a new administration comes in, they come in with a number of very short-term priorities they want to do right off the top. And so CSIO, we try to act very quickly, and we put into place a rule very quickly and try to get it in, within a couple of months so that it can take effect for the next plan year. And that's what happened here. And so these plaintiffs went to the judge and said, Judge, please stop this rule in its tracks, like right now, because otherwise we're going to be harmed immediately. And so the judge basically instructed the agency to stop implementing the rule, not let it come into effect. It's technically a stay. I mean, I think loosely we've been calling it an injunction or enjoin, which is I think what you said, Brittany. Technically it's a stay. It doesn't matter. It's the same thing. A judge has instructed us to stop the implementation of this rule. And of course we have stopped the implementation of the rule. This is like very late in the cycle. We're sort of moving into open enrollment within weeks. And so we have had to undergo all kinds of convulsions to sort of issue new instructions to insurance companies to come in and alter all their plans to sort of make them compliant with the judge's directions. Because plans had issuers had set up their plans to comply with the program integrity rule provisions throughout the spring. And now they suddenly had to sort of backtrack a bunch of that stuff. And so we have been the last couple of weeks furiously working with industry and I mean like working very hard, not with anger, like with passion. We've been working very hard with states and with insurance companies to sort of get all these changes in, and hopefully we will pull it off without major chaos come open enrollment. But we have certainly increased the risk of major chaos in open enrollment, or at least that a number of plans will not make it across the line, will not get on, or won't get on until like late in the cycle, or states or plans maybe like forget it this year, we'll skip this year, we'll try to catch next year because it's too late. So that's what an injunction is. And the litigation on this case will continue. The Department of Justice will continue to make the government's points in this litigation at the Court of Appeals, as well as in the district court. This is only a preliminary ruling by the district court. This is the trial court, because the rule was about to come into effect, and so the judge has to make like kind of a snap ruling. And so they do that. They say this is preliminary, but based on what I see before me, based on sort of like, who's going to get harmed and all this sort of stuff, let's put a stop for now. But the litigation will go on for a while until we work out sort of what the, what is lawful and what is not. But I'm hoping that in going into open enrollments in the future, that we will not be in such a terrible operational position.
Well, thank you for explaining that. As we're coming to the top of the hour here, I have one more question for you, Jeff. If there is one thing that you want the audience to take away from our discussion today, what would it be?
Well, for folks who are, have a stake in and are interested in health policy, I will reiterate that I do think that long term, I'm very bullish on these markets. I'm very bullish on the individual market and its and our ability as a country to turn it into sort of the backbone of the commercial coverage industry, because it is the one market that is there for, Medicaid for folks who are of lower income or otherwise qualify for Medicaid, but for everyone else, the individual market is there. The exchanges are there, and notwithstanding the political turbulence that comes from time to time, I do think long term this is a market that is going to continue to grow and going to be there for employees, employers, for Americans of all ilk, to get coverage and to have that security. I think that coverage is really fundamental to long-term health and also extremely fundamental to long-term financial security, which is really important. We will see. We will continue to bring transparency to the system, and try to keep the system as user-friendly and as available as we can. Brittany, you've had many colleagues over at CMS. There are lots of folks over here who are working hard every day to make all of these programs work as well as they can for the American people. These are our colleagues in the Center for Medicare, our colleagues in the Center for Medicaid, as well as SSIO, and as well as all of the other folks in CMS and HHS that support that mission. I really appreciate the fact that all the folks in the audience are interested in these topics and want to understand them. They are very technical and very complicated, but I do think long term, the only way this country is able to sort of fill in these cracks and make the system work optimally is for more people to sort of have an understanding of the stakes and what is happening. Thanks everyone for participating. I enjoy these sessions and find them very valuable.
Well, thank you. Okay, well, this brings us to the end of this month's Northern Virginia Health Policy Forum. Thank you, Jeff, for your public service and for sharing your expertise and insights. And we hope you'll come back soon for a third visit to the forum. We know that there are some questions that we may not have been able to answer, and if you have any, please feel free to send them in, and we'll answer those questions in our post-forum memo. Before I close, we just sent a message in the chat with links to subscribe to our monthly newsletter and to view the Northern Virginia Health Policy Forum website for more in-depth insights into reimbursement issues and current health policy. Thank you for being here today and enjoy the rest of your day.